This is the approach to dyspnea, the dyspnea pyramid. And the pyramid is divided into 4 rows. The bottom row is the lungs, pulmonary causes of dyspnea. The next row is cardiac, the heart, cardiac causes of dyspnea. The third row is blood, and the fourth is acid base. You'll see why I choose that syringe image at the end. We're going to start at the top and work our way down. These are the causes of dyspnea. First at the top is a metabolic acidosis or a respiratory alkalosis. Those, you may be saying, are not diagnoses. That is correct. This is a way of putting in a catch-all so that you don't have to litter this advanced organizer with every possible diagnosis. A respiratory alkalosis, someone who's breathing really fast, probably breathing really fast from something else. And if there is a metabolic acidosis, their dyspnea may simply be their attempt to correct their acid-base status. At the end, I'll show you what tests to get, and you'll see why this is so useful. In blood, there's also only 2 main diagnoses. That is no blood, called anemia, and bad blood, which is carboxy or methemoglobinemia. Now, the key to this is that this pyramid is not a list of every diagnosis you could possibly think of. The idea is, just like on a website, roll over this anemia box and a drop list comes down, right? And you then can select from any of the causes of anemia. The reason why that is because it doesn't matter what the cause of anemia is. The symptoms of anemia are the symptoms of anemia. And once you arrive at this complaint is from anemia, then you can click in and get into the more specific diagnosis. Which type of anemia is it? The heart row has 3. That is an MI, CHF, and arrhythmia. The same concept is true of CHF. Doesn't matter if it's ischemic, non-ischemic, systolic, diastolic, valvular failure, or whatever cause. People with heart failure exacerbations are going to present with dyspnea on exertion, paroxysmal nocturnal dyspnea, orthopnea, pulmonary crackles, JVD, peripheral edema. Once you've nailed the diagnosis, click, the drop down comes out, and now you have to figure out exactly what is the cause of the exacerbation or what type of heart failure do they have. But this is a way of initially approaching someone's complaint to narrow down where you should be looking. Now, the last row is plentiful, and it's the pulmonary row. In the chest pain approach video, we talked about those things that are in contact with the pleura causing pleuritic chest pain. Those things can also cause shortness of breath. And if they have dyspnea with a pleuritic chest pain, that significantly narrows down your differential. And those things are the pneumothorax, the pneumonia, the pulmonary embolism, a pleural effusion, and a pulmonary cancer. These involve the pleura, so can cause a pleuritic chest pain, as well as dyspnea. Then you have obstructive lung disease, and obstructive lung disease comes in the way of both asthma and COPD. And if there's obstructive lung disease, of course, there's going to be restrictive lung diseases, formerly called interstitial lung disease, now referred to as diffuse parenchymal lung disease. And to round off the chart, diffuse alveolar hemorrhage and ARDS. All right. When you get the phone call, this person is acutely short of breath. You say, I'm on my way. But you should order 4 tests. Definitely 3, but I argue for the 4th. The 3 tests are going to be the arterial blood gas, a chest x-ray, and a 12-lead ECG. I throw in there the BNP. It can be misleading, but it's helpful to have objective evidence of volume overload or not. Watch this. Arterial blood gas with electrolytes is going to give you the electrolytes if there's an acid-base disturbance and anemia, if there's a low hemoglobin or not. The entire top half of the pyramid can be assessed with an ABG. That's why it's a needle, because they have to draw an ABG. The chest x-ray can then assess for any evidence of heart failure, as well as give you a decent look into the lungs. Not a great one, but certainly if it's causing dyspnea, it should likely be severe enough to either show up on an x-ray or get evidence of another disease that isn't diagnosable by an x-ray, such as obstructive lung disease. The 12 lead helps you with MI and arrhythmia. I used to teach chest x-ray will show you evidence of CHF, and it does, but a BNP is now readily available. The thing is, though, that when you get the phone call, don't just say, I'm on my way. Say, order me an ABG, chest x-ray, 12 lead, and BNP. When you arrive 2-3 minutes later, none of those things would have been done, but the action would have been started. Arterial blood gas is drawn by respiratory therapy. The chest x-ray is taken by a radiology tech. The 12 lead is done by an EKG tech, and the BNP is drawn either by the nurse or the lab. Lots of people need to be informed to get things moving. If you arrive and say, oh, I don't need those things, you just cancel them. Right? But if you wait to get to the bedside to get tests you know you're going to need anyway, it'll take even longer to get those results back. Before you hang up the phone, ask about SATs. In general, the SATs are low. You want to give oxygen. The goal in the hospital is not to maximize oxygenation. It is to keep the pulse ox greater than or equal to 92%, except in COPDers, where the goal is 88 to 92. Get the phone, order an ABG chest x-ray, 12 lead BNP, confirm the SAT, and tell them to apply oxygen. Check out the oxygen delivery video in this series. And then, as you arrive at the bedside, keep an open mind using this advanced organizer as a means of keeping track of all the diagnoses it could be. Then, as you approach your history and physical, start shaving off the ones it's probably not, and this will help you arrive at the right answer. That is approach to dyspnea.